Hi, good afternoon. Welcome to Blunt Dissection, the podcast where we take clinical topics, cut through the noise and get to what actually matters. I'm Tom Gillham, a practicing GP in Hertfordshire, and each month I sit down with a consultant colleague to talk through interesting clinical topics that land in primary care, or those things which, as a GP, I just want some quick advice on to help manage my patients. We keep the episodes short, around 15 minutes, because I know genuinely how busy general practice is and how busy you all are. The aim is to get straight to the key points, the practical takeaways, and the things that you'll actually remember when you're back in the consulting room. We'd love to hear your suggestions for any topics going forward. Please do pop them in the suggestion box below. This week is our first ever podcast, and we're talking about one of those presentations that definitely sharpens the focus, testicular torsion. And for this episode, I'm delighted to be joined by Miss Shabnam Undre, consultant paediatric urologist at East North Hearts Trust since 2015, who's been working on improving outcomes in torsion since 2018. And today's episode is called Save the Ball. Miss Undre, thanks for joining me. Welcome.
Thank you. Thank you very much.
It's a pleasure.
It's a topic which obviously I'm very passionate about, so I'm delighted to be your first speaker.
No, it's lovely to have you. Okay, so let's start off a straightforward question for you. I'm sure you'll be able to answer it. What exactly is testicular torsion?
So testicular torsion is, and I have a little prop here, as you can see, it's the testicle actually dangles from its blood supply.
Yeah.
And if it twists, which is what torsion is, it kind of wraps around the blood supply, as you can see, and thereby stopping the blood flowing to the testicle.
Yeah.
And this is a critical event. And if you don't untwist it, you could lose the testicle permanently.
Okay. And just give me a sense of how common this presentation is.
So the incidence is, if you learn about the statistics, it doesn't sound like it's very much. So it's about 4 in 100,000. But the lifetime risk is 1 in 800, which is actually not that much. So you will have heard people around you, you will definitely have heard anecdotes, people you know will have had or experienced somebody they know with testicular torsion. Yeah. So it is a common thing. And most importantly, the impact is quite severe.
Sure. So we'll definitely come back to the impact. What about the sorts of men, boys that present? What's the commonest age for this to happen?
So the commonest age is either in the first year of life or around puberty. So we say between 11 and 18, but it could literally happen at any age. So no age is exempt, although the slightly older men, 40, 50, 60, it would be unusual for them to have torsion. But anybody in the younger age group, we would certainly recommend thinking about torsion as one of your differential diagnoses.
Yes. Typically, I would imagine a teenage boy, but I didn't realize it happened quite so young in the first year of life.
Yeah, actually, it has 2 peaks. One is the first year of life, and the second peak is in puberty.
Okay. So tell us about how it would present, and I'd be particularly interested to know how it presents in the baby, but actually give us the more common presentation in the older child or the teenager.
Unfortunately, in a baby, it's very hard to know that they have torsion. And in those cases, we usually do end up losing the testicle because the parents may pick it up as a bit of redness, a bit of swelling. By the time it comes to the healthcare provider, it is usually quite late. So I'll talk about the age group that is more relevant to practice, to GPs and to primary care and to the emergency departments, are patients who present with pain.
Yes.
So it could be sudden onset of pain. It's quite severe.
Yeah.
It lasts more than an hour. There may be some abdominal pain or groin pain associated with it, and sometimes it could mimic appendicitis. So patients coming with abdominal pain, you should think about whether this could be torsion in a boy. There could be nausea, vomiting associated with it, and actually you could have pain even at rest.
Yeah. So it's that rapid onset pain. So from almost being pain-free to quite intense pain.
Yes. And
over an hour or so. And if it lasts for more than an hour, that's a real red flag.
Yes.
Yeah. Okay. And I think you mentioned when I spoke to you about this before, and I didn't appreciate this, but it can often be linked to trauma. So if there's been an injury in sport, is that right?
Yes. So trauma, however trivial, may trigger a torsion.
Yeah.
So if there are testicles which are more prone to being torted, for example, a minor kick or a football landing in your groin might twist the testicle. So, and then we might be swayed that it's actually trauma and not think about torsion as a diagnosis. So I would be particularly cautious if there is some trauma associated with it, because you should still think about torsion as a result of trauma.
Yeah, of course. So what you're thinking is, well, it's probably a groin injury or something from the football hitting the area, or some kind of musculoskeletal thing, or bruising. But in fact, that's a torsion. So it's that thing about lasting more than 1 hour that's crucial.
Exactly.
Yeah. So tell us about why it's really important to pick up on that immediately. What's the danger or the risk?
So like I showed you with the prop there, the blood supply can cut off quite soon after the ball starts to twist. And after about 6 hours of being twisted, the salvage rates go right down. And after about 24 hours or 48 hours, the salvage rate is very, very little. So it is quite critical. We do call it a life-saving procedure, limb or life-saving procedure. And 6 hours is the golden window, really, for the highest salvage rates.
Yeah, so that's 6 hours. And we, again, at medical school, it was all about time is testicle. So
exactly.
Get on if you suspect it, get it referred in.
6 hours from getting the pain. So if you imagine all the other delays that, by the time the child actually tells somebody, that tells their teacher, their parent, somebody comes and picks them up from school, then they might go to primary care. So, I mean, the time actually, it sounds like 6 hours is a lot, but it is very little time to get to theatre within 6 hours.
So there's quite a lot of pressure on GPs not to send patients to ED, which I totally understand. We should make referrals where appropriate and not just offload to ED. What's the danger of, or what should we do if we think there's a torsion?
So I think this is one of those scenarios, and we're working really hard with our national campaign to include it in one of those NHS 111 red flag areas, with stroke and heart attack and things. And this is absolutely one of those areas where you shouldn't be thinking about, should I not put pressure on the ED? You absolutely must send them in because it's so time critical. So if there is sudden testicular pain which lasts more than an hour, you don't have to worry about, am I going to burden the system? No, this is absolutely critical. You do need to send them in, and send them into the appropriate place, to a place where there is emergency available, where they can operate if they need to, because we need to minimize the number of encounters that these patients have. So they should go to the definitive place where they can have their surgery. Yeah,
so if a patient's in East North Arts, it would be straight to the Lister.
Absolutely.
Yeah, okay, got that, thank you. And if we don't crack on, if we don't action, if we're a bit if we're unsure, there's a delay, what happens? What's the risk?
Yeah, I mean, all the studies that we've done with the NC-POD and GIRFT, and including my own study, we've shown that there are numerous factors for delay, before the children tell their parents, from awareness in schools with parents, with the children themselves, then the delays between primary care and secondary care, and even within secondary care. So once the patient has come to emergency department, timely intervention, seeing them promptly, getting them to theatre. So there could be any number of delays which might lead to eventual testicular loss. And the reasons, are numerous, but the impact is so severe on the child or the young person. It could be fertility issues, the psychological issues, just the fact that you've lost their confidence. So I think the effects can be quite long lasting, and for the parents, the guilt of not bringing them in, and even the healthcare providers.
Okay, and we talked about trauma masking the condition, and we talked about loss of testes if we don't intervene quickly, obviously. What can we, primary care, GPs, I'm sitting in my surgery in Welwyn Garden City, what can we do to make sure that we do everything we possibly can to salvage or to not miss these things?
So I think we've been working on a national campaign called Save the Ball, which we're trying to educate boys, parents, schools, and we've got a PSHE recognized program where we've sent out letters to 27,000 schools. We've developed lesson plans, we've got videos, we've got a website. So I think it would be really helpful if, the curved posters which have been designed, which has our QR code on it, if all GP surgeries could put the posters out into their GP surgery so that the boys and the parents can take pictures of this QR code, go and watch the videos at home, spread the word, with their friends and schoolmates. Anyhow that we can get the information out would be useful. And secondly, having a very, very low threshold for thinking about testicular torsion, not being afraid to send them in. It doesn't matter. We keep telling our trainees, don't worry if you've taken too many torsions to theatre or non-torsions to theatre. Nobody will fault you for exploring, but they will be upset if you've lost a testicle. So I think creating awareness is the most important.
Yeah. And just going back to that, again, I'm interested in the actual procedure itself. Is that a quite straightforward procedure, Shabnam?
Yeah, it's a procedure that's on both the general surgery and the urology curriculum and has been, although mostly undertaken by urologists. Our ST3s onwards should be able to do it. It's quite straightforward. I mean, they have even described in the books that you can untort it manually without even reaching theatre, but we don't recommend that. But it's a straightforward operation, which can be learned quite easily.
I don't think you'd expect us to try and untort it in primary care.
No,
that's a relief. Good. And just tell us more about the website or the Save the Pool campaign. Is there a website we can go to get those resources?
Yeah, it's testicularhealth.info, and there are videos which have been designed with primary school, with the secondary school boys around 11 years old, and they have helped us to design the lesson plans and the videos. So it's all very child friendly and easy to understand.
It sounds fantastic, and thank you for all the work you're doing in this area. It's clearly a very important topic, and you're clearly a real champion for it. So, thanks for that. And are there any last comments you want to make? Any final punchy take-home message? I think you've covered most of it, but any last thoughts you want to share with our GP colleagues?
I mean, all I'd say is just have a very, very low threshold for anybody in that age group with testicular pain. Don't delay. Just send them in so that we can save the ball.
Save the ball. That's great. Shabnam, thank you so much for joining us today. Thank you for listening and watching, and please do send in your suggestions for future episodes. That's the first episode of Blunt Dissection. Tom Gillham and Shabnam Undre from the Lister Hospital. Thank you.
Thank you.